بسم الله الرحمن الرحيم الحمد لله رب العالمين وصلى اللهم على محمد وآله الطاهرين. I want to say thank you to my colleagues, moderators and everybody. Good morning. Today I want to present to you the subject of monocular elevation syndrome, the treatment, type and management, how they present, how we can manage them. The monocular elevation syndrome, as it is named before as a double elevator palsy. They think that the elevator of both elevators in the eye, they are responsible for the inactivity or inability for the eye to be elevated, to be shifted upward, and that is why they said they named it as double elevator palsy. In fact, it is wrong because they see that the condition, it is not related to the elevator only. It might be blamed the central nervous system and also restrictive, and there is many theories about the etiology. The types, the clinical types of the MID, it is also called, abbreviated as MID. MID is clinically classified first that with the inferior rectus restriction, and the other type is with elevator weakness, and the third one is the combination of both. What are the clinical features? They present usually as limitation of elevation in adduction and abduction. And this is maybe the patient in the primary position, but still he has no ability to elevate the eye. The second presentation is the hypotropia, that the patient presented with the downward displacement of the eye. And the third one is the chin up position and association with ptosis or pseudotosis. 50% of those patients having true ptosis. The most important thing is the examination here, and there is three important examination steps which guide us toward the treatment. First is the force duction test. Second is the force generation test and the saccadic movement on attempt to elevation. Force duction test, as you know, this is the way how we can move the eye against the field of the action of that muscle. And if it is resist and there is no free movement, what is called the free movement, that you can easily move the eye against the field of that muscle, this means that is restricted. Is very important for the management. The second is the force generation test. Is that's mean when attempt to move the muscle, we mean upward in our condition, that there will be some of the force, you feel it by forceps. This means that the force generation test is positive. And finally, we can get very important information when we are moving the eye upward. There will be some of the oscillatory saccadic movement. Again, this means that there will be some of activity of the elevators, which is important as the force generation test for the how we can manage those patients. What are the indications for surgery for the MID? First is that where we have when we have large vertical deviation, and second is that the abnormal head position, and you know why these are the indication. We have three ways for the treatment. The first way is that the inferior rectus should be recessed when it is restricted and the force reduction test is positive. The second way is that when the inferior rectus muscle is not restricted, and in this case we have to do medial and lateral rectus muscle transposition just beside the superior rectus. And the other is the inferior rectus recession and superior rectus resection in a special condition, which is depending on the examination we are talked about. This is one of my patient. This is presented an early presentation with severe hypertropia plus esotropia and also ptosis. The eye cannot move upward totally, and at the same time, in this condition, this is also a rare association. There is also esotropia. We think that this patient not only cosmetically is affected, as also is functionally very affected, and the problem here is how you can do the surgery for this baby, 6 months. The main problem really is not for the correction of the hypertropia, but the problem is how to correct the ptosis. Because the ptosis correction will causing exposure. Because this, on examination, it have very strong force reduction test and very restricted muscle, and it is even appear on the picture, and also is association with the esotropia. There will be a very contracted muscle. Really, what I plan to do to this patient, visual acuity is not cannot be examined. Patient not cooperative. Force reduction test was strongly positive. Anterior segment, posterior segment look normal, and the levator function is null. So what is my planning is that to do the multi-stage. The first stage is to do the large inferior rectus recession for our condition, and at the same time, because esotropia is present at the same time, I also decide to do the recession of the medial rectus. At first, when I did this, I don't expect at all it will be corrected for the hypertropia because it's severe hypertropia. So I did this surgery and then I will do the other surgery for the correction of deviation before going to the ptosis. But during surgery, I saw a very, very tough inferior rectus, which is merely fibrous tissue. What I did even during the suturing, and I couldn't even catch the muscle during the suturing of the placement of the suture in the muscle. So I decided that I think this muscle will be functioning even if it is recessed. I do very big recession, and I do hang back. You have to know that the inferior rectus muscle, you have to be suture it very well because it's tight even in the normal condition. This condition make me to make a very large recession using a hang back suture. Of course, with the medial rectus also suture to a maximum level, which is 7 millimeter. And after that, I did the second stage, which is the frontalis suspension. This is patient post-operatively. The hypertropia, looks 95% is corrected. And after a sling operation, I did also the sling operation, and also I hope not to causing exposure keratopathy, because it is high possibility, because we don't have pills phenomena we expect from this very large very contracted inferior rectus and no pills phenomena. This is the first case. The second case is late presentation of patient with hypotropia, ptosis, but fortunately better and good levator function, or at least fair. You can do something for her. And this patient, on examination, it was amblyopic, slightly 2660. Force reduction test was equivocal at that time. For generation test is positive. Anterior segment, posterior segment are normal. Levator function above 8 millimeter. So I plan to do a multi-stage for her. First stage is that inferior rectus recession and superior rectus resection. And I didn't see they use the recession resection for this. And usually they do transposition, and I do the transposition. But for this patient, I insist to do resection because I feel that the muscle is working in the superior rectus muscle is working. That's why I decided to do a resection at the same time. And the second stage was levator palpebris superiorus resection. The first stage, the patient now corrected, the hypotropia is corrected and the eyes is ortho, there is no deviation, 3 months post-operatively. And this is, the patient is corrected after 3 months. We did the LPS resection, levator palpebris superiorus resection, and the patient ortho and good position of the eyelid and the eye position. Conclusion: variable presentation and anomalies associated with mid, and we have to search for every associated lid anomalies and other things. Treatment usually require multi-stage. You have to tell your patient the sequence or the ptosis will not be corrected with the first session, maybe. Time of the surgery is also difficult to be decided because lack of cooperation, especially in early, that I face a lot of problem during examination. Type of the surgery depends on the case presented, and final result cannot be predicted because of functional limitation. And thank you very much.
Thank you, Dr. Hashim, for this nice presentation.